Assalamu alaikum wa rahmatullahi wa barakatuh. I'm going to introduce pregnancy with diabetes mellitus. We will discuss about definition, prevalence, gestational diabetes and pre-gestational diabetes, screening and diagnosis, fetal effects, maternal effects, management of diabetes antenatally, intrapartum and postnatally, and take-home message. Classification of diabetes in pregnancy. Diabetes in pregnancy, either pre-existing diabetes or gestational diabetes. Pre-existing, from its name, it's either type 1 diabetes or type 2 the diabetes, and patient will be diagnosed. Gestational, either pre-existing, but patient maybe she doesn't know, or true gestational diabetes mellitus. So the definition for pre-gestational, any degree of glucose intolerance with onset or first recognition during pregnancy does not exclude possibility that unrecognized glucose intolerance may have been present before onset of pregnancy. Pre-gestational diabetes is diagnosed when the woman has diabetes before pregnancy. Prevalence, 22 million women between 20 and 39 years have diabetes in 2010 data. Expected to rise by 20% in the next 10 years, 54 million women with impaired glucose tolerance or pre-diabetes have the potential to develop gestational diabetes if they become pregnant. First, I will start by gestational diabetes, the physiology. Why some patients, they are prone to have gestational diabetes, and it's usually it will appear in the second trimester and it will be more increased in the third trimester. Because of insulin resistance during pregnancy, it will emerging in the second trimester due to placental hormones like progesterone, cortisol, human placental lactogen, prolactin, and estrogen also contribute. Some patients cannot balance insulin needs and develop GDM, it's gestational. Placental insulinase enzyme and obesity. Of course, gestational diabetes, one of the risk factors will be obesity. How I will screen and diagnose these kind of patients, because when they will come to the clinic, they have this diabetes or they are prone to have gestational diabetes. Women should be screened at first visit as feasible if the patient at high risk for gestational diabetes. Who are these patients? A body mass index of more than 30, they are obese, first degree relative with diabetes, personal history of GDM, that she has a previous history of gestational diabetes, previous macrosomic baby, macrosomic more or equal 4.5 kg. Family origin with high diabetes prevalence, like ethnicity. Patients have average risk factors will be screened at 24 to 28 weeks. Actually, they are either low risk, average risk, high risk. The high risk, which I talked about, the low risk if patient is less than 25 years old, no previous history of diabetes, no family history of diabetes, she is out of the ethnicity that risk for diabetes, glucose test is not recommended. But the average risk, we have to screen them between 24 and 28 weeks of gestation. How I will go to screen these patients? I will do oral glucose tolerance test by either 2 steps or by 1 step. If we will go by 2 steps, we will give 50 grams of oral glucose challenge test, followed by diagnostic 100 grams, 3 hours oral glucose tolerance test for those meeting the threshold value in the glucose challenge test. It will be usually after 1 hour, more or equal 135 to 140 mg per deciliter. So when I will do 50 grams, if the reading will come more or equal 135 to 140, so I will go for the next step. It's 100, and I will give the readings in the next slide. 1 step, we will go for 100 grams, 75 grams with 2 hours oral glucose tolerance test. As it's showing this table, this is 175 grams. 100, the fasting, we will take 3 hours. The fasting will be 95. 1 hour 180 milligram per deciliter, 2 hours 150 milligram, and third hour 140. If 75 gram, this is the one step, it will be 95. The fasting 1 hour 180, and the second hour 155. This test, we will take 2 readings from this 100 gram or more. It will diagnose that they are gestational diabetes. It's confirmed diabetes. From the 75 gram, we will take 1 reading or more. It will diagnose them. The test also should be the patient arranged before it for 8 hours fasting, not more than 14 hours. And we will instruct the patient in the clinic when we will do this test. Maternal and fetal complications. Actually, for the gestational diabetes, it's not like pre-existing diabetes from the complications, at least from the congenital malformation side, because it's unlike the over diabetes rate of fetal anomalies will not appear to be increased, because as we said, they are prone to have this from the second and third trimester, not from the first trimester, like pre-existing. Women with elevated fasting blood sugar, increased rate of unexplained stillbirth, increased frequency of hypertension, increased risk for cesarean delivery because they are prone to have macrosomic babies. And I will talk in more details with pre-existing diabetes about maternal and fetal complication. After we diagnose that patient, she is diabetic, what we will do, so we have to start management. How we will start management? Actually, for them, they will start by diabetic diet. It's a kind of multidisciplinary team by dietitian, nutritionist, and obstetrician, endocrinologist. So we will start to have this diet which contains carbohydrate intake limited to 40%, 20% as protein, and 40% as fat. Pharmacological methods are usually recommended if diet modification does not consistently maintain the fasting plasma glucose level less than 95 gram per deciliter, or the 2 hours preprandial or postprandial less than 120. Insulin treatment is the first line for us during pregnancy. The starting dose, how we will calculate, actually according to the weight of the patient. So the need each trimester, it will be increased. We will start from 0.7 units per kg in the first trimester, second trimester 0.8, and 0.9 to 1 unit per kg in the third trimester. Oral hypoglycemic agents with either glyburide or metformin, but not approved by FDA. It can be given, it's safe, but limited study about long-term side effects on the newborn. How I will adjust the dose? For after I calculate the total dose need of insulin, I have to divide it. We will use regimen, 3 kinds of regimen, either mixed start, which is ready and available, regular, and MPH, 30 to 70. We will divide 2/3 morning and 1/3 in the evening. The other regimen, if I will go for regular and MPH, also I will calculate the total need of insulin. I will divide it by 2/3 in the morning and 1/3 in the evening. The 2/3 in the morning, I have to divide it to 2/3 and 1/3. Also 1/3, it will be as a regular short acting, and the 2/3 intermediate MPH. The evening dose, I will divide it by 2 halves. The first half, it will be regular, and the second, it will be MPH. And we will monitor the blood sugar readings, 5 points, fasting, postprandial. My aim in pregnancy is different than non-pregnant ladies. Maybe they will see that the target is to have fasting 95, not more than this. And the 2 hours postprandial not to exceed 120, and 1 hour 140, not to exceed this. In non-pregnant lady, I think these readings, it will be okay for them. But for us, during pregnancy, we are very restricted for these readings. The third regimen, if you will use the short acting and long acting, so we will divide the total need in 2 halves. The first half, we will divide in 3 pre-meals, pre-breakfast, pre-lunch, pre-dinner. This is about regular. And the long-acting, it will be the other half. It will be given at bedtime. Pre-gestational diabetes, this is pre-existing diabetes, is observed in 1% of all pregnancies, and either type 1 or type 2. Type 2 is the most common. Diagnosis of over-diabetes in pregnancy, fasting, it will be at least 126 mg per deciliter, random plasma glucose at least 200, and HbA1c at least 6.5%. Fetal complication. In pre-existing diabetes, the complication is more, as long as patient she will be affected by many years before. So spontaneous abortion will start from the first spontaneous abortion, preterm delivery, malformations like neural tube defect, cardiac malformations, caudal regression sequence. Altered fetal growth. Either if there is vasculopathy, vascular complications, so she will be more prone to have a baby small, IUGR, intrauterine growth restriction, or fetal macrosomia. So the baby will be big in size because hyperglycemia in the mother, it will lead to hyperinsulinemia in the baby, and it will lead to more lipid and increase in weight for the fetus. And it will affect us in our decision, of course, later on when I will talk about mode of delivery. Unexplained intrauterine fetal death. Also, it's a very serious complication when we will miss the fetus due to this disease. Polyhydramnios and neonatal complication when the baby will deliver. We are suspecting to have hypoglycemia, respiratory distress syndrome, polycythemia, hyperbilirubinemia, hypocalcemia, hypomagnesemia, and cardiomyopathy. What about maternal complications? She will be prone for infections, either urinary tract infection, respiratory tract infection, vulvovaginitis during pregnancy. Increased risk of hypertension, as we said, with vascular complication if she is pre-existing diabetes. So she is prone to have hypertension and preeclampsia. It will be increased by 25%. Maternal distress due to polyhydramnios, difficulty in sleeping in supine position, diabetic retinopathy, microaneurysm, hemorrhage, and proliferative retinopathy, diabetic nephropathy, diabetic ketoacidosis. Diabetic ketoacidosis also, they are prone to have this at a level of less than 200, even during pregnancy. At 170, they are at risk to have this complication. Risk of perinatal injury during delivery due to macrosomic baby, like shoulder dystocia and Erb's palsy. And also for this mother, postpartum hemorrhage, polyhydramnios, and difficult delivery. So risk for postpartum hemorrhage and infection after delivery if she will deliver by CS, or infected episiotomy if she will deliver by vaginal delivery, and peripheral sepsis. For us, these kind of patients, pre-existing diabetes, they need care. Preconceptional, actually, we have to start with them. And they have to be compliant and regular follow-up in our clinic. So my preconceptional care, it should be about glycated hemoglobin. We are aiming to have it before less than 7% because the risk of malformations increase fourfold at a level more than 10%. So we have to control also blood pressure, blood sugar, preprandial levels 70 to 100 mg per deciliter. Peak postprandial values 100 to 129 milligram per deciliter. She has to start to have folic acid 400 microgram per day from 3 months pre-pregnancy. When she is planning to have a pregnancy, she has to start pre-conceptional 3 months, and added to them 150 microgram of potassium iodide is a recommended prior to conception. Folic acid, she will continue till the end of the first trimester to reduce the risk of neural tube defect like spina bifida and encephaly. Screening for retinopathy, also the patient should be asked for ophthalmology to do fundoscopy to see if there is any complication. And this one should be evaluated and monitored every trimester and for 1 year postpartum. Nephropathy, as indicated, of course. Nephropathy, we have also to assess the urine kidney function, like creatinine and urine albumin to creatinine ratio. In the first trimester, patient, she got pregnant, so she will come to the clinic for the antenatal visit. So patient should be admitted each trimester to control blood sugar. Because also the requirements of insulin may increase by each trimester due to increase in the placental hormone, and it will affect the readings. Insulin treatment to over diabetes, the best treated with insulin, of course. And as I told before about insulin types, our aim to have the fasting is less or equal 95, pre-meal less or equal 100, 1 hour not more than 140, 2 hours not more than 120, and at midnight to be more than 60, not less than this, and HbA1c at less than 6%. Second trimester, aspirin is advised to start at 12 to 16 weeks to reduce the risk of PET. Maternal serum alpha-fetoprotein 16 to 20 weeks we have to do, and detailed anomaly scan between 18 and 20 weeks. Fetal echocardiography for the baby, as we said, they are more prone to have cardiac malformation. So it's better to be done a fetal echocardiography 18 to 20 weeks because of risk of cardiac anomaly, 5 times increase in mothers with diabetes. In the third trimester, regular antenatal care in the clinic every 2 weeks, fetal assessment, biophysical profile, CTG, and we will make sure that blood sugar is monitored, and we will plan for delivery. If it's controlled, she can deliver at 40, 41 if it's controlled, and if it's uncontrolled, recommended to deliver at 38 weeks. Mode of delivery according to the estimated fetal weight. Contraindication if the estimated fetal weight is equal or more 4.5 kg. During labor, intrapartum, the usual dose of intermediate acting insulin is given at bedtime. Morning dose of insulin is withheld. Intravenous infusion of normal saline is begun once active labor begins or glucose level decrease less than 70 mg per deciliter. So the infusion is changed from saline to 5% dextrose and delivered at a rate of 100 to 150 ml per hour to achieve a glucose level of approximately 100 milligram per deciliter. Glucose levels are checked hourly using a bedside meter, allowing for adjustments in the insulin or glucose infusion rate. Regular short-acting insulin is administered by IV infusion at a rate of 1.25 units per hour if glucose level exceed 100 milligram per deciliter. This is intrapartum. Then postpartum care. Insulin resistance decrease dramatically immediately postpartum, and insulin requirements are often roughly half the pre-pregnancy requirements. So if the patient is pre-existing diabetes, either we will put her back on her dose pre-pregnancy, or we will give her half the dose which she was taking during pregnancy. Contraception. We advise her for contraceptive method and should be discussed and implemented. All kinds of contraception, unless no contraindication for them, she can take it. Screen women with a recent history of gestational diabetes mellitus at 4 to 12 weeks postpartum. That gestational diabetes patient, I will stop the treatment for them, and I will recommend for them to follow this after 4 to 12 weeks to make OGTT again postpartum using the 75-gram regime. Women with GDM found to have prediabetes should receive metformin to prevent diabetes. Women with a history of GDM should have lifelong screening for the development of type 2 diabetes or prediabetes every 1 to 3 years. And we will avoid infection, of course, because they are more prone to have infection, and encourage breastfeeding. So our message here that diabetes with mellitus is very critical disease and it's very common with pregnancy. It has many maternal and fetal complications. And as we can to control the blood sugar pre-conception or during the pregnancy, we will have, inshallah, good maternal outcome, good fetal outcome, and the patient, her risk will be like the non-pregnant ladies. And thank you. شكرا. Yes. Potassium. Potassium, it's kind of nutrition. Yeah, it's newly recommended by 2022 American Association. It's recommended with folic acid, preconceptional. I have read about it, kind of nutrition and maybe prophylactic for some electrolyte imbalance for that pre-existing diabetes patient. Like this. It's recommended by ADA 2022. Actually, in our practice, no, we are not giving the iodide, potassium iodide. We will see if it's available as tablet by pharmacy. We will ask and we will arrange if we can give. This is by ADA, American Association Society. This is the newly recommended. 2022.
The other question regarding the institute.
Yes.
You mentioned that pricing for which is regular and intermediate sensitive.
Yes.
For those patients.
Yes.
Well, because of the data interesting with was data was for example, this
for us in OB/GYN يعني in pregnant ladies we are using this MPH and regular. If we will change to other kind of insulin, so we have to go back for the endocrinologist advice because it will be more easy to control by MPH and regular because we have to adjust the doses. Maybe I will increase, I will reduce this. So if fasting is high, for me, I will increase the MPH dose if postprandial, so I will increase the night dose. If I will change the doses according to the readings. So we are famous to work with MPH and regular, and that's what is recommended for us as obstetrician. By American guidelines, by Royal College guidelines, and even if you will use that bolus, which you are talking basal insulin, yeah, I think it's not recommended during pregnancy. It will increase the side effects like vomiting or nausea. I'm not sure about these side effects of this kind of insulin.
Because it's easier for the patient to have electricity. When you once or twice and you think this once a day. When bolus is really pre-primary.
هلا نحن this last regimen which I talked about, that long acting with the short acting. But they have to take pre-meal injection, pre-meal, pre-fast, pre